Bonjour à tous, bienvenue au deuxième épisode des Entrevues Code ViE. Welcome to the Code Life Interviews, Episode 2 of this six-part series. We have put together a series of panels to mark the 200th anniversary of the Montreal General Hospital, the MGH, a pioneer institution of the McGill University Health Centre, which coincides, of course, with the McGill University's 200th anniversary celebrations. 200 years ago, the Montreal General Hospital was created to treat populations that were being devastated by deadly epidemics of typhus, cholera, and smallpox. Then 100 years later, in 1918, came the Spanish flu. That led to staff shortages and overburdened wards at the MGH, but it also led to the creation of the Federal Department of Public Health and locally a new school of nursing at McGill University, and of course to a shift in discourse to address the unsanitary living conditions in low-income households. That's where most were affected by influenza at the time. So over the past year and a half, the MGH has been once again facing a pandemic. We all have. Et avec nos invités aujourd'hui, nous allons explorer comment la COVID-19 a affecté les soins de santé, mais aussi comment d'autres crises de santé publique ont transformé la médecine historiquement. Alors avec nous, Dr. Dawn ViH, infectious diseases specialist, now a familiar face for a lot of people in Montreal and a medical microbiologist at the MUHC. Also with us is Dr. Nikita Paquet, Associate Professor at McGill University's Department of Medicine in Clinical Epidemiology, also a researcher at the MUHC RI. And on a aussi France Paquet, Nurse Manager for the Infection Prevention and Control Department of the McGill University Health Centre. So thanks to all of you for accepting our invitation, for joining us. I want to start with you, Dr. ViH. Just set the stage for us a little bit. We did a bit of a historical recap there, but you, just in researching and getting ready for this panel, you found some interesting facts about how the MGH has its own place in history in dealing with pandemics.
Yeah, so it's very interesting because the MGH has had to encounter 4 major epidemics or pandemics. As you said before, smallpox, flu, HIV, and obviously COVID. And that smallpox was really a pivotal point because the history is so fascinating. The first patient to present, coming off the train with a fever and rash was actually diagnosed with smallpox at the Montreal General Hospital. But the physician wanted to protect the patients within the MGH and refused admission to that patient. And that patient had to go to another hospital where it unfortunately led to an outbreak there, and then of course an outbreak to the rest of the city and of the province, leading to lots of deaths. And I think that was a critical junction where the Montreal General Hospital had to realize that they had to do both, right? They had to protect the patients, but they also had to serve people in the community. And then you can see that evolution in the HIV and flu and COVID eras where the MGH and the MUHC has been really at the forefront of taking on patients. Remember, the MUHC wasn't a designated center for COVID patients by the government at the first decisions, but when the number of patients just increased, the MGH and the MUHC stepped up to take them on.
They certainly did. So, France, I want to talk to you about le rôle que vous avez joué. Vous avez joué un rôle clé en contrôle des infections, en prévention des infections. Dites-nous, historiquement, les infirmières ont toujours été pionnières dans le domaine, incluant au MGH.
Oui, en fait, si on pense à Florence, parce que comme infirmière, on ne peut pas faire autrement que penser à Florence, qui est née en 1820, donc déjà 200 ans, mais Florence a été pionnière parce que elle est arrivée en guerre de Crimée et les choses les plus importantes pour elle, c'était les 3 D, là, la poussière, the dirt, the diet and the drains, donc de l'eau potable, d'ouvrir les fenêtres pour aérer, de s'assurer que les gens mangeaient bien, les lits étaient changés. Donc, elle était finalement une des premières à faire de la prévention et du contrôle des infections parce qu'à ce moment-là, la pandémie, c'était les soldats qui mouraient en milieu hospitalier. Et elle utilisait aussi, c'était une statisticienne, la première femme statisticienne acceptée à la Société de statistique, le Royal Society of Statistics. Et elle faisait des graphiques avec le nombre de décès, qu'est-ce qui pouvait être évité. Puis elle a révolutionné. En fait, aujourd'hui, on utilise encore ça, les statistiques, pour démontrer l'importance d'un phénomène ou pour que les gens puissent saisir l'importance de certaines... En fait, quand on fait juste regarder les décès, là, puis on est capable de montrer ça en images, c'est beaucoup plus parlant.
Oui. Puis spécialement aujourd'hui, avec les technologies qu'on a, on a été parfois bombardés, mais on a tellement plus d'informations que dans les années précédentes, évidemment. Puis, Dr. Paquet, now most of your research has focused on HIV. There's a lot of famous HIV researchers who've contributed to what we know about the COVID pandemic. Tell me a little bit about their role and how their response has, or how they've guided the COVID response.
Thank you. So pandemics have changed the course of medicine, have impacted, have led to change in medical practices. And HIV, basically, most of the researchers who have been in HIV, most prominent amongst them is Tony Fauci, they were able to switch over because of the extensive experience they had in dealing with pandemics at a systemic level. So many of the patterns that they could draw in all the responses that they crafted at the systemic level could be applied to COVID-19. So that was one. The other thing that happened was we had these platforms that were available, like I'm thinking of the rapid testing platform or the self-testing platforms that were available, and they were available by companies had them, and they were able to kind of morph and use it for COVID-19, except that the COVID-19 antibody tests kind of failed, and then they were morphed into COVID antigen tests, and now we have self-tests. So this rapid, fast tracking of innovation, which basically bears down to necessity is the mother of invention, that really happened because people had a lot of experience in this space. Not necessarily in terms of the transmission dynamics and the fact that, this is a respiratory pathogen versus, HIV, which has a different transmission dynamics. But in terms of the systemic level responses, I think most of the researchers involved in HIV kind of switched to COVID. And it's also, there is a term for it called the COVIDization of research, where about 500,000 publications were produced only on this topic for almost a year. Mm-hmm. And so there's a lot of information now. Of course, there was less information then, and now we have a lot of information to deal with it. The thing that bothered me the most was the delays in response that happened. Policies and guidelines were not updated. So that led to loss of lives. And much of if you look at historically, if you kind of look back and look at the problems that happened, they were all about, hospital delays or, rapid turnaround time was, there wasn't a rapid turnaround time on PCR testing. People died sometimes in some countries because they couldn't get the test results in time, so they couldn't be admitted. So there were these systemic bottlenecks in the system that could have probably been avoided and could have saved lives. So, yeah.
And Dr. ViH, talking about this influx of information and trying to keep up with all of it, that was also an issue for just the general public. And you ended up being one of the spokespeople for knowledge and for analyzing data and basically fighting misinformation. I'm wondering, is that if you ever imagined you'd find yourself in that position pre-COVID?
Yeah, no, I actually found myself in this new role, right? So I'm a clinician, I see patients, and I'm a scientist, I do research. But what the pandemic really showed us is there was so much information coming out at such an advanced speed that it led to changes in practice, it led to changes in policy, and we needed to be able to absorb that as a medical community and convey that to the public, because the public, all they saw were just changes in policies. And without understanding the context, a lot of them thought that the governments or the medical community were flip-flopping. And we had to show them that this is not flip-flopping, this is actual science in real time. When the data comes out, we've got to integrate it, we've got to change our strategy, we've got to change our plans, and that's what good science is, right? So when I was through you and with others, trying to communicate that to the public, it really became a very important tool, right, in the fight against COVID, that we had to make sure that the public were as aware of what was going on as the medical and the scientific community.
Mm-hmm. And it remains a challenge. I see you're still very active on social media. Is that a role that you think will remain for you? Is that part of your job now? Do you see it that way?
Yeah, so part of my job has always been to communicate with the patients, but it's usually the patients that I follow and take care of. Now the population for all of us are really the people that we live with, and it's our community. And so I think if we can communicate accurately to our community in full transparency, sometimes admitting that we don't know or we don't have all the data, I think that would be the most accurate thing that we can do to help the people that we live with.
And so, France Paquet, I just want to go back to you avec votre rôle sur le terrain. vous, comment est-ce que vous avez vécu cette expérience-là, les changements d'information rapides, les changements de politique, essayer de suivre tout ça et de mettre ça en place dans un hôpital avec des milliers et des milliers de personnes qui travaillent là, et les patients qu'on va voir aussi. J'imagine que c'était très difficile.
Oui, et pour faire du pouce sur ce que Don a dit, généralement, on dit qu'entre une recherche puis son application sur le terrain, notamment en soins infirmiers, on dit que ça prend 10 ans. Là, c'est pas 10 ans, là, c'est quelques semaines. Des fois, les recommandations étaient faites de l'INSPQ, puis là, c'était tout de suite, là, le lendemain ou le surlendemain, les changements de politique devaient être faits. Donc, il y a eu une mobilisation extraordinaire de l'équipe pour modifier ces politiques-là, pour faire de l'approbation. C'est long, généralement, c'est long de faire approuver des politiques. Là, c'était approuvé rapidement. Tout le monde a travaillé ensemble, mais le défi, c'était de transmettre cette information-là à tous les employés ou tous nos professionnels de la santé qui donnent des soins, qui sont au chevet. Donc, comment on transfère l'information à ces gens-là en temps opportun quand ils en ont besoin. Et on a révisé notre façon de faire. Des politiques qui étaient très longues, essayer d'avoir des formules plus courtes. On a eu l'équipe des soins infirmiers qui était sur le terrain les week-ends, en soirée, pour transmettre l'information aux infirmières quand elles en avaient besoin, pour essayer d'avoir le plus de gens possible et puis que tout le monde fasse la même chose, parce que ça peut être angoissant pour les patients. Une infirmière le fait d'une façon, une infirmière le fait d'une autre. Et entre collègues aussi, où est-ce que tu as obtenu cette information-là? Donc, c'est tout un travail d'équipe d'être capable de transmettre l'information rapidement. Et c'est ce que ça a montré. Là.
Pensez-vous que ça, c'est un des changements qui est là pour rester?
Absolument.
Vous souhaitez, j'imagine?
Très, très fort. Pour que on a appris qu'est-ce que l'infirmière a besoin de savoir au chevet et elle doit être capable d'y accéder rapidement. On a révisé le site web, juste l'intranet du CESM a été révisé pour que l'information soit plus facile à trouver. Mm-hmm. Et oui, j'espère définitivement que ça va rester. Là, la vitesse à laquelle les protocoles sont approuvés, que les changements sont faits, les outils pour faciliter le transfert de cette information-là. Oui, il faut que ça reste.
OK. Puis, Dr. Paquet, COVID, we know, has served as a catalyst for change in so many fields, whether we're talking about working from home, business adaptations that were necessary, obviously, in medicine. What's been the most significant one in your view? You touched on digital health and how that's been important also to your work.
Exactly. And I think that prior to COVID, there's a lot of inbuilt patriarchy within medicine where, we've done things in a certain way, and so there's a reluctance to change. And so prior to COVID, there was a reluctance towards adoption of digital technologies. But because of COVID, because we couldn't meet humans, because we were confined to our homes or in our private spaces, I think digital health, telemedicine, there's been such a big uptake. So for example, the statistics show that telemedicine uptake was 1% pre-COVID, and it's shot up to 70%. So many of the companies have mushroomed to provide this, and they've also realized that they don't need to visit doctor every 3 months. Some of these consultations can happen over phone. So a lot of new models are going to evolve out of this pandemic, and it's actually going to be good because it's going to be for the greater benefit of society. The other good thing that came out of this was data analytics. So many dashboards mushroomed in different parts of the world, and they were not just done by the medical community, but also by the non-medical community. People who were involved in data visualizations, they could predict hotspots ahead of time. They could use drones. For example, in India, they could use drones to figure out how many bodies were being burnt to kind of get an estimate of how many deaths were being underreported. And then the other good thing that I think that happened was public health came into public consciousness. It was kind of like in the back burner. People who turn off the tap to prevent contamination of drinking water are not really celebrated. But I think now public health and epidemiology have kind of shot into the public consciousness, and people understand terms. They understand the difference between an epidemic and a pandemic. And I think the last thing that really happened was personalized health. All of this thing has become really easy now. Use of sensors, trackers. You don't have to explain it to a normal person. And mRNA vaccines, as soon as China released the genetic code, those vaccines were just not being used, and the way they were developed in record time. I think that is one of the things that can be a gift, and it could be used for so many of these other infections that we've been struggling to get a vaccine. For example, for HIV, we've been trying to get a vaccine for such a long time. So that heralds a cure or sort of, end to the pandemics not just one but many. So I feel that pandemics really have shown not only they have shown what the society is capable of doing. The other part of the pandemic that I feel sad about is the inequity around vaccines. There are countries on the planet that don't even have, populations that haven't even received one dose, but there are other countries that have talking about booster shots. I think the generosity of humanity has to be called upon so that we can end the pandemic in all parts of the world. Otherwise, this is not going to end. This is going to continue for another 5 years.
And we've shown that we can do some incredible things, Dr. ViH. One of the positives is just how quickly scientists were able to work together to come up with a vaccine, months into the pandemic. It was so fast. How has that changed? How do you see that change in terms of working with clinicians, this integration of clinical research and clinical practice?
So, as a clinician scientist, one of the things that drives my research and the research of other clinician scientists is that research is care. But what's come out in the pandemic is that data saves lives. As data was coming out, we needed to integrate that data into medical algorithms, into clinical care, into how to, get medications to the most vulnerable, get vaccines to the most vulnerable. And the fact that the pandemic has underlined the importance that data saves lives makes us realize now that going forward, especially for an academic hospital, we need to be able to study the patients that we take care of to better take care of them. We need to understand their clinical data. We need to take biological samples and do cutting edge research on that so that we can take that information and in warp speed reapply it back to them and to the next people who become sick so that we can make them better. And I think one positive aspect of the pandemic is exactly that now research is a critical component of clinical care. They're not separate and in silos, they are hand in hand, and that's the way we've got to go forward.
That's something that's been, the desire to de-siloize has been present. Having worked in the medical field a little bit alongside you for a bit now, I'm seeing that is such a critical issue. And Dr. ViH, this kind of brings me up to your biobank and what you're doing. The MGH and the MUHC are playing a critical role, maybe a more low-key one, but an important one. Tell me a little bit about what the biobank's doing and ultimately how you hope it will serve Montrealers and beyond.
Right, so at the MUHC, we've been very fortunate that through the government of Quebec and through the MGH Foundation, we were actually supported to develop a biobank. So what that biobank does is that every patient who is hospitalized at the MGH or MUHC who has COVID is approached to participate in this biobank where we collect their clinical data and blood samples and other types of biological material. And what we're trying to do is to understand, why do some people become sick? Why do some people become severely sick or deathly sick? Others don't. Why are their household contacts not becoming sick? So this is the purpose of the biobank, is to take advantage of this unfortunate situation so that we can transform tragedies into triumphs. We can learn from unfortunate deaths so that we can prevent the next one. And the MGH Foundation has really been at the forefront of helping us build this biobank, which, by the way, in the province of Quebec is the second highest in terms of recruitment of patients. And every one of those patients that we can study helps us understand the next patient with COVID and also the next patient when we're talking about another infection down the road. Mm-hmm.
And so I see you nodding. Is there something you wanted to add to that?
No, I totally agree with what Donna is saying, and has also been, I think it has catalyzed so many things that I think it will be hard for us to go back to the normal pace that we were used to, where research was, in a silo and knowledge translation was like an event. Here it happened, everything happened in tandem. So that integration that we talked about for a long time, there is an example now. So I hope that we don't go back to the old normal. Mm-hmm. If this is the new normal, I hope we can integrate and move forward. And that should be the example, and like that is the case study that we need to have. And we should just refer to that and move ahead, rather than look back and say, okay, we have to go back to what we used to do pre-pandemic. So there are lots of things that we need to integrate as we move along. Mm-hmm. And if we don't do that, again, we have to, the problem with humans is that we always like to learn lessons, and history will repeat itself. So those are the things that we need to do. So, the other thing that the COVID-19 pandemic has really shown us is that across the world, across countries, it's the underprivileged that have taken the toll, right? Like the pandemic took a toll on the underprivileged and most of them died. So that misinformation that Dawn was talking about, I mean, part of this reason why people couldn't show up when they got infected, they thought it was the flu, and by the time they actually were in the third or the fourth day, they were so hypoxic that they couldn't even show up at the hospital in time. So I think that kind of misinformation, we need to really attack that misinformation. Mm-hmm. We can't have people asking us if vaccines work today in 2021.
Et France, on parle de, c'est beaucoup dans les nouvelles, les transformations en nursing. Pouvez-vous me dire, en tant qu'infirmière, on est en transformation profonde, quels sont les changements que vous espérez sont là pour rester?
Bien, le rôle de l'infirmière continue de se développer. Puis moi, ce que je vois dans les prochaines années, avec le vieillissement de la population, je suis pas mal certaine qu'on va être capable de travailler encore plus ensemble et les champs de compétences de chacun des professionnels de la santé vont vraiment être exploités à leur maximum pour que tout le monde puisse contribuer à sa façon à assurer qu'on va continuer de donner des soins de qualité à la population. Alors, on arrive de loin, hein, il y a 200 ans, le rôle de l'infirmière était bien différent de ce qu'il est aujourd'hui. Il y a 100 ans, les infirmières étaient formées dans les écoles, dans les hôpitaux. Après ça, la formation était offerte en milieu scolaire. Maintenant, à l'université, on s'en va vers un bac pour toutes les infirmières. On ne sait pas quand, mais c'est quelque chose qui est envisagé. Alors, de plus en plus, là, le rôle de l'infirmière va continuer d'évoluer. Là, j'en ai l'intime conviction.
Mm-hmm. Puis vous, y a-t-il quelque chose en particulier du côté du contrôle des infections et prévention des infections qui a changé, que vous souhaitez qui va continuer aussi? On parlait de la rapidité des approbations, mais est-ce qu'il y a autre chose aussi, quelque chose qui vous a peut-être surpris au cours de la pandémie?
Enfin, la résilience des infirmières et puis de tout le personnel soignant là, et la capacité de travailler en équipe. C'est sûr que les gens sont fatigués, là, on peut pas nier ça, mais on n'a jamais eu des beaux taux d'hygiène des mains comme maintenant. Je pense qu'on n'a plus besoin de dire que c'est important. Oui, en fait, on a toujours besoin de dire que c'est important de se laver les mains, mais maintenant, je pense que c'est concret et tout le monde sait à quel point c'est important de se laver les mains. Je pense qu'il y aura de moins en moins de gens qui vont venir travailler avec des symptômes d'infection respiratoire et j'espère que c'est là pour rester parce que notre clientèle est vulnérable, parce que nos collègues peuvent l'attraper aussi. L'utilisation de la visière ou de la protection oculaire, c'est quelque chose qui n'était pas vraiment utilisé ou pas tant là, quand moi j'ai commencé comme infirmière il y a déjà plusieurs années. Puis ça fait partie de la pratique maintenant. Donc, il y a des choses qui vont rester.
I have a question. We're starting to take some questions from people who are watching us, from listeners. Thank you. I'm going to put this out there to either you, Dr. ViH, or Dr. Paquet. How can we improve the access to medical data, in your opinion?
So that goes back to a systemic issue, right? Which is that the reason why access to data has been problematic, and we have dealt with this repeatedly, like running to the brick walls all the time, is that we need to protect that data because there's a lot of confidential information in there, right? So the agencies and the Quebec government have a strong desire to make sure that data is protected. On the other hand, sometimes you can overprotect. And what happens then is you restrict. And when you restrict, you make it problematic or at least difficult for researchers to be able to access that information. And then you can spend a year and a half historically to get information when you don't have a year and a half because that's how long our pandemic's been going on. And so these are the issues. And I think that the people have awakened to this reality. And I think that there is an understanding that this cannot take that long to be able to do this kind of research that we're talking about.
Another question that we have coming in is, do you think COVID will lead to faster development of vaccines in the future?
Absolutely. I mean, set the stage.
Of course, yes.
Well,
and to add to the data bit, I think in this age where there is a growing investment in digital health, there's a lot of talk at the international level about who owns the data. So there are a lot of issues around data confidentiality. So there are ways to anonymize the data to prevent hackers or people with vested interests in monetization who may get access to data, which is the reason why data is protected or data are protected. I think there has to be that they have been working on these rules and they have to now fast track those rules and agreements that have to be in place so that data can be shared between countries for rapid development of not just drugs and technologies, but also in digital health too. There's so much that is out there that can be improved. So I'm pretty sure things are going to happen and they're going to move at a faster pace.
And just to go back to the point about the vaccines, I think we have to understand the context, right? Which is, yes, during the last 18 months, we went from no vaccine to a vaccine. But that actually, overshadows the fact that there was over a decade's worth of research to develop the vaccines, right? So it's not like we're just developing vaccines on the spot, and we're certainly not cutting corners scientifically or regulatory wise to be able to get the vaccines out to the public. What they are is we're seeing the fruit of the labor that has been going on. And I think what this will tell us is that we can, all these ideas that had, the idea of an mRNA vaccine, the idea of all these other vaccines, they are worth investing in, because down the road, we will probably encounter another bug that will require a vaccine. And it's not at that time that we're going to develop the technology, it's now. And I think that's what people, have come to realize, that we have to invest in research.
I think, and one of the things that is the bottom line is science delivered, healthcare workers delivered. I mean, across the spectrum, the only thing that delivered was science. If we didn't have mRNA vaccines, we would not be sitting here talking about it. So we have to give that tribute and respect to healthcare workers and not give them a hard time if they're requesting you to get vaccinated. I mean, who delivered? Dawn is telling you the story about Anne and Frances. I mean, how they worked so hard. So I think, period, the thing that didn't deliver was leadership. Leadership in many countries really failed to deliver. They did not do the right thing at the right time.
But as Dawn was saying too, it was so difficult to predict what's going to happen as well. But I want to ask you another question that's coming in about tracking. There was a tracking app many tracking apps that came up a few months ago. Mixed results. Do you see a usefulness to a tracking or tracing app at this point in time?
Well, that's a digital health question, exactly. So I'll let you answer that.
I think the answer to that is it depends. If tracking is used to inform public health, I would endorse it. But if tracking is used in nefarious ways, because the problem with tracking is how is it being used. So far, there hasn't been great data on what happened with tracking apps, and that's primarily because people are not sharing the data. If they really shared the data, we would know exactly from different parts of the world as to how effective they've been. But if you really have to deploy it, I think there is a lot of value that you can get out of. You can really do good transmission studies if you know it.
In line with what you do, maybe it's rapid testing that is the better tool. It's sort of emerging as a better tool, is it not?
So there's, if we're talking
or
about...
am I wrong?
Well,
it is always, testing has always been the cornerstone. The problem with vaccination is that with vaccines taken over, testing has fallen by the wayside. But I hope that Dawn would agree that even now there is so much of a value that we could bring to the table by really instituting these rapid testing in outbreak settings, because if the prevalence or the incidence of COVID is high, you can actually test them. You have to train people to do it right. That is the most important thing. But if you can detect more infections, you can triage and you can make sure that they don't advance. And that is really important. And testing has really fallen by the wayside. And that is one of the sad things that I think that has happened with vaccination.
I mean, the thing about rapid testing is it isn't a pregnancy test, right? It's a little bit more complicated, because the question is, how good does your test perform and who are you testing it on? If you're testing it on people who have symptoms, that's very different than if you're looking for the asymptomatic person. And we know with COVID, there's a lot of asymptomatics. So you're not going to have, for example, an asymptomatic pregnant person, right? So there's an example of where it's not a pregnancy test. And so you need to have the right test. You need to have people trained appropriately. appropriately, and you need to know what are your algorithms. I actually work with schools, and they actually have rapid tests given to them by the government, limited numbers, and we actually have to come up with algorithms that's actually based on, well, what's the community transmission rate right now, and then we can figure out what to do. But France, there's clearly a need, because you can imagine healthcare workers or patients who are not ready to get themselves tested because they're willing to dismiss it. There is clearly a value there.
Well, absolutely, and what it shows is that for all other, if we look at prevention of hospital-acquired infection, we bundle intervention. Well, for COVID, we're bundling interventions. Where there's the vaccine, there's PPE, and there's social distancing, there's quarantine, there's vaccine, and all of that, it all goes together. And that's with all those interventions that we're actually able to tackle it.
And to add to their points, we've never really talked very carefully about algorithms. I mean, we've done this in HIV, so there are smart algorithms that you could use to kind of detect. But because we invested a lot on vaccines, kind of like, dissemination of knowledge and making sure that everybody got jabbed. If we had worked a little harder on rapid testing and algorithms ahead of time, I think we would be in a position to deploy them in an intelligent manner. And to add to your point, Lucira is a test, like the molecular tests that are available that have been approved by the FDA. And those molecular tests are as good as RT-PCR, like in the RNA tests that are being used. So if we could figure out a way to provide those tests, and for sure in clinically symptomatic people, then we can actually detect more infections at a faster rate. So there's that molecular advantage, but because it's not in the consciousness, and because there's not been a lot of training and investment, they're not ready for uptake, but they would be a valuable tool in this fight against COVID.
I want to put a last question to you from our viewers is, how can we help globally with the pandemic at this point, with the COVID response at the MGH, for example? What role can we play for the benefit of our community, but beyond? It's a big question.
Well, I do want to answer at least from a local perspective, and I want to build on one point that France mentioned, which is I think locally we need to appreciate the efforts that the nursing staff have made. And of course, other allied healthcare professionals like physiotherapists and nutritionists. But remember that nurses, including at the MGH, went into patients' rooms in the first waves without very much knowledge about the COVID, risking their lives and their families' lives to take care of patients. And I think we need to appreciate that. But of course, the MGH can contribute on a global scale, because from the clinical level, the database of information that we collect on these types of patients, the biological materials, the capacity to do trials, either drug trials, infection control trials, allows us to provide a piece to the jigsaw puzzle that's global.
Yes, and also there's a wealth of knowledge at the MGH that could be disseminated, to the countries that are really facing the impact of the pandemic. I would really add that vaccine equity, I think we can do much more to kind of share the vaccines that we have, the booster shots that we probably don't need, so that the healthcare workers in other countries can be saved. And information and knowledge. I think that is the best gift that you can give to the world, because the world is really struggling with misinformation. And those would be.
En français, avez-vous quelque chose à rajouter là-dessus? Qu'est-ce qu'on peut faire, même localement, pour contribuer, quelqu'un qui nous écoute, qui nous regarde aujourd'hui, comment est-ce qu'on peut aider comme patient ou comme citoyen à aider un peu à contrôler la pandémie puis la réponse COVID?
Bien, on continue de se faire dépister quand on a des symptômes, on continue de porter son masque quand on vient à l'hôpital, même si on aurait bien envie, tout le monde, de le retirer. On continue de garder nos distances et on rapporte les symptômes. Je sais, c'est pas facile, on est tous tannés.
Ouais. Mais c'est l'essentiel finalement. On revient toujours à ça. Ce qu'on peut faire, on peut commencer avec ça, puis c'est déjà beaucoup.
Oui, ça fait une différence parce que c'est pas facile pour personne et vraiment tout le monde en a plein les bras et tout le monde est tanné, mais.
But if you look at the history of the MGH, we started off talking about 4 major pandemics, right? And each one, the MGH has been marked historically with the smallpox, HIV, clearly MGH and the MUT have been at the forefront, and same thing with flu, and same thing with same thing with COVID. There is, the MGH and the MUHC have been at the forefront. We have taken on responsibilities that we didn't necessarily need to. For example, absorbing patients in the earlier waves. We are doing cutting edge research that is provincially, nationally, and internationally, at the forefront of discovering information. When I said before that the data was coming in at an amazing pace, that's because scientists and clinicians at the MGH and MUHC were contributing to that. And I think that is going to be our role to the center stage globally, is to contribute local care, but also to contribute globally scientifically.
So that everyone can benefit.
Also set an exemplar. This is just an example of good care and good practice. That in and of itself is a gift to the world, because there are dime a dozen examples of where people have dropped the ball on patients, where just the gaps in the healthcare system have led to loss of lives, and policies that were not implemented, guidelines that were not updated, massive loss of lives you're talking about. So I was looking at the estimates of global COVID-19 infections, and I think it is a gross underestimation, because many countries have not even reported their deaths accurately. So if you add that, you can compound it, you can actually exponentiate it by a factor of 5 to 10 to actually get the true estimate of infections across the world.
Thanks to your good work, we're making a difference. I'm not, you're making a difference. So thanks very much. Thanks for this and for your insights on this such an important matter. Thank you for being with us and taking the time. Merci à nos invités et merci à vous tous d'être là avec nous. Alors, notre entrevue sera également disponible dans quelques jours sur la chaîne YouTube de la Fondation de l'Hôpital Général de Montréal. Alors, n'hésitez pas à la partager avec vos amis, avec vos collègues. And if you wish to play a part in redefining medicine post-COVID, you can give to the Montreal General Hospital Foundation. You can go to the website codelife.ca. Et aussi, si vous voulez aller voir l'exposition virtuelle, vraiment une belle exposition, c'est très bien fait, qui retrace 200 ans d'histoire de l'Hôpital Général de Montréal. C'est disponible au hgm200.com, mgh200.com. Super intéressant. Alors, moi, je vais vous voir à la prochaine fois pour November's Code Life Interview. Merci et ne manquez pas notre prochain épisode qui sera le 10 novembre prochain. Merci, au revoir.